Welcome everyone to today's webinar. I am Mary Rectoris with Becker's Hospital Review. We will begin today's webinar with a presentation and panel discussion, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are really looking forward to hearing your questions. Also, in about a week following the webinar, we will be sending you a copy of the presentation to the email that you used to register. And at this time, it is my pleasure to start today's webinar by introducing our panelists. Dr. Donald Tsai is Executive Vice President for Clinical Outcomes Management at MPA Healthcare Solutions. He is also an adjunct professor of surgery at Northwestern University and professor emeritus of surgery at the University of New Mexico School of Medicine. At MPA Healthcare Solutions, Dr. Tsai provides clinical leadership in analyzing and evaluating clinical performance, guiding quality improvement, and creating incentives for coordinated, cost-effective care. It is my pleasure to turn the floor now to Dr. Tsai to begin the presentation.
Thank you, Mary, and if we may have the first slide, and thanks to all of you that have dialed in for the webinar today. Just a brief line about what MPA Healthcare Solutions happens to be. It's an analytic group here in Chicago that has been involved in risk-adjusted assessments of outcomes for over 2 decades. And in the last 10 plus years, we have been very much involved in the design of episode-based payments, which will be the focus of our discussion today. We have had major interactions with all of the components and stakeholders in healthcare, insurers, hospitals, health plans, medical societies, and even federal government grants. And we have made it a practice that our research work is published in peer-reviewed journals so that there's no questions about the validity of our methodologies. Next slide, please. Well, it would be no surprise to anyone listening to this presentation that payment reform is sort of on everybody's minds at the present time. And over the last decade, there have been a host of different methods used to try and reduce the cost of healthcare while preserving the quality of the product that's delivered. And so pay-for-performance initiatives, public reporting, health savings accounts, even punitive government measures, the Readmission Reduction Act, the Never Events policies have all attempted to reduce costs, but in the final analysis, you would have to say that they've been somewhat alike rearranging the deck furniture on the Titanic. They have had very little impact of a positive nature to this point. Next slide, please. So we're going to talk about bundled payments today. Bundling the payment of a healthcare episode, we think, is the logical solution to carry forward meaningful ways of changing the way care is paid for. So we're going to define what a bundled payment is. We're going to talk about defining what an adverse outcome of care is. We're going to talk about the importance of risk adjustment in assessing outcomes and costs. We're going to talk about the critically important issue of post-discharge adverse outcomes. This is clearly a very important aspect as one moves forward into a bundled payment environment. And last, but certainly not least, is comparative effectiveness. How can we know what the results are? How can they be benchmarked to provide physicians and hospital providers a clear focus on how they need to improve care? Next slide, please. So the bundled payment concept is pretty straightforward. It is making a single payment for the episode of care. It's not unlike buying an automobile. You don't pay for all the component parts. You buy an automobile. And so a single payment would be made that covers the inpatient facility costs if it's an inpatient episode of care, total professional costs, and then the post-discharge care for the patient up to a defined length of time. And we've commonly used 90 days for inpatient care. It may well be a shorter period of risk as one looks at ambulatory procedures, but that would need to be defined by all of the parties as to what's going to be the appropriate length for the bundle to extend after the patient is discharged. Bundled payments have commonly been recommended for inpatient surgical care. There is considerable interest in ambulatory or outpatient procedures being covered by bundles. Inpatient medical admissions, I think, will logically fall under a bundled payment strategy, as will mother-baby payments in obstetrical care. An area that's being explored by many investigators at the present time is outpatient chronic disease management, and whether you can define a bundle for a year in the life of a diabetic patient or a patient that has chronic obstructive lung disease. Next slide, please. The concept of the bundle, I think, is fairly simple. And we've used a surgical analogy since that's been the area of my greatest interest and the area in which we have done the greatest amount of investigation. But the total payment would come down to what is the cost of a routine case, one that goes from beginning to end without any adverse event. And to that routine cost would be added the equivalent of a warranty, just like buying an automobile. And the warranty would be the probability of an adverse outcome times the risk-adjusted cost of that adverse outcome. Next slide. Here you can see some of the elements and the issues, the incentives that are created in the system. With the global budget, it rewards efficiency. If you can deliver the care at a cost less than the budget, it would enhance margins for the providers. It penalizes overutilization. The warranty, on the other hand, serves as a check and balance. It rewards high quality care. If you have fewer complications than would be predicted, then you have improved margins. But similarly, if you restrict utilization to a point where the quality of the final product is impaired, this system will penalize those who are withholding care by having higher rates of adverse outcomes. A critical component in this consideration is having risk adjustment. Each patient is unique. You have to have appropriate risk adjustment to avoid cherry picking. That question comes up all the time when I make this presentation. What's to keep hospitals from having only the favorable risk patients? Well, if the risk adjustment is done correctly, it will correct for adverse case selection. And it rewards high quality care, and it ensures patients to get high quality care, because those facilities, those providers that can't deliver care to the benchmark will not fare well under this model. Next slide. So here you can see the simple analogy. The automobile, you have the expected defect rate, And the warranty is computed by that expected defect rate times the expected cost of repair. And with healthcare, we're proposing that that same concept be applied in computing a warranty that would be paid with the routine payment in every case. Next slide. As with the automotive industry or any other product, you have to know what your costs are. What are the parts of what you do that could go wrong? And so we have itemized these costs. What are the costs associated with deaths, both during the hospitalization and following discharge? We've used prolonged length of stay outliers as a measure of significant inpatient complications. Readmissions will prove to be a major focus under the bundled care strategy, because I think that's the one area that has the greatest opportunity for being impacted, and emergency department visits that are not associated with readmission. These all become components of costs that have to be woven into the fabric of the warranty. Next slide. Next slide, please. The key in making bundled payments work is that the traditional divisiveness that's existed between payers, physicians, and hospitals is going to have to be transitioned to one of cooperation. And, you know, when I say this to surgical groups, people ask if I've lost my mind to think that this could really happen, but I believe that it can happen, because aligning the interests and people working in a coordinated fashion is going to be the key to improved margins and better quality of care for patients. The other thing I like about the concept of the bundle is it maintains the flexibility of hospitals and physicians to do what's right for the specific patients that they are caring for. This provides flexibility by having more monies paid for the very complex cases and giving clinicians the responsibility and the opportunity to tailor care to the specific needs of patients. Next slide. So the adverse outcome, next slide. The adverse outcome is a critical piece to what we do at MPA. And part of that relates to the fact that what is a complication anyway? If one hears presentations on complications, if one reads the literature, my God, the rates of complications of operations vary all over the place. That's because there's a lack of accepted definitions. There's certainly very little emphasis on the severity. You commonly count fairly innocent events with the same score as you do catastrophic events. That's not very helpful. If you itemize every potential complication in a surgical case in the hospital, as I will illustrate for you in a minute, the rate of complications is phenomenal. They are not all created equal. Surveillance for complications is inconsistent. It's been my observation that facilities that commonly self-report very low rates of adverse events aren't looking very hard. And so that's led us to look at alternative methods rather than counting specific coded events on the medical record. And finally, complications have to be viewed in light of the patient's risk at the time of presentation. Next slide. So these are the elements that I think are important in measuring outcomes of care. That the measure has to be objective, it has to be consistent, it's got to be reproducible, it has to be clearly defined so that providers understand it, it's got to be risk adjusted. I don't like self-reported things. I hate to be so skeptical in my old age, but I am. I would like for outcomes to be objectively determined by the record and by the patient's outcome and not by what someone says. I think it ought to be a no-fault determination. Not everything is going to be preventable. Reporting complications is enshrouded in people having a sense of guilt that they've done something wrong. Well, you know, I've taken care of a lot of surgery patients over a lot of years, and I can tell you bad things happen. Bad things happen when you can't really discern why. So we've got to get away from the fault mindset, have a reporting process of no fault, and then we sort out what could have been and couldn't have been by having a comparative analysis to a benchmark. And finally, at the end of the day, you want a composite evaluation. Out of the 100 patients that you've cared for with Operation X or disease Y, what was the composite outcome at the end of the day? Next slide. So we have used these 4 elements illustrated for you here in measuring the adverse outcome of surgical care. Did the patient survive the hospitalization? That's pretty easy. Did the patient have an inpatient complication as manifest by a 3 sigma outlier for their inpatient care? Did they get readmitted to the hospital after you've excluded those things that really are not relevant to the index operation or index hospitalization? And then one of the things we have found particularly interesting are the number of post-discharge deaths, many of which are not associated with readmission, especially in the Medicare population. So one has to have a comprehensive data set to be able to track what actually happens to those patients over time after discharge. Next slide. So risk adjustment. All patients are certainly not the same. Next slide. So we have a different problem in medicine than exists in manufacturing. We like to use the warranty concept from manufacturing, but unfortunately our inputs are highly different. The patients are intrinsically different. The case severity increases as the risk for adverse events increases, and accordingly, one has to take that into consideration as you are looking prospectively at defining outcomes and costs. And I think that it's important that we calibrate the rates of adverse outcomes and the costs to quality providers. And generally, we've found that about 80% of hospitals and 80% of physician providers gives us a good index of what should be, with eliminating a relatively small percentage of facilities from the aggregate computation. Next slide. So our prediction models are just schematically represented for you here. We look at what is the risk of a patient having an inpatient death, and we develop a model to estimate that. We then look at all live discharges and what's the probability of having a prolonged length of stay. And then of those live discharges, we identify who died after discharge without readmission, and what were the significant readmissions that brought patients back in the hospital, so that we can come up with an aggregate estimate of what was the adverse outcome for those patients. Next slide. And when we have all of those components, we then can expand our warranty a little bit so that the routine cost then has the probability of each of the 4 elements times the risk-adjusted cost of each of those 4 adverse outcome elements to sum up and give us a predicted cost over 90 days that could be anticipated for a given patient with a given risk profile. Next slide. And here you see an illustration of how much risk adjustment makes a difference on the budget for coronary artery bypass grafting. In the case 1 scenario, you have a 65-year-old patient that has no risk factors. I'm not sure I've ever seen one of those, not for a coronary artery bypass graft anyway. But as you can see, the warranty is really pretty small. It's about 1.5% of the total budgeted routine cost of an uncomplicated case. However, if we add congestive heart failure and lung disease for this patient, well, now you see that the budgeted routine cost has gone up 50%, and the warranty for the probability of an adverse outcome has gone up by a factor of nearly 5. And in case 3, we now have an 85-year-old with congestive heart failure, lung disease, a recent myocardial infarction, and chronic renal disease. And now you can see that the budgeted routine cost has gone up substantially, and the warranty has gone up 30 times from what that which was identified in case 1. Next slide. So our group has now worked hard at 32 separate clinical categories for designing bundled payments. We are vigorously working in the arena of designing outpatient bundled payments for procedures that are now being done in the ambulatory area. We're now seeing traditional inpatient operations transitioning to outpatient. So much to my amazement of having a long career in surgery, I never thought I would see the day that total joint replacements would be done as an outpatient, that patients would have spine fusions and be sent home the same day, but that is in fact happening now. And so while inpatient care has been a principal focus in the many different procedures that you see illustrated for you here on this slide, I think the outpatient focus is coming, and that bundles will be implemented for procedures being done in the outpatient venue. Next slide. So post-discharge events. Next slide. This is the black box of patient care. We don't often know what happens to all of our patients when they're discharged. 20 to 40% of readmissions following inpatient care occur at hospitals other than where the principal care was provided. Here you can see a much quoted article from the New England Journal, which looked at some 13 million Medicare patients and identified that of 13 million Medicare patients, 19% are readmitted in 30 days, and fully 1/3 are readmitted by 90 days after discharge. The graph on your right illustrates, which for me, what is a very alarming observation. And that is that at 30 days, 52% of the patients that had been readmitted had not seen a physician following discharge. And if you go all the way out to 90 days, 22% of readmissions within the 90-day period of time had not been seen by a primary care physician or whoever was responsible for their inpatient care. I think this is telling us right away how we can look to the future for improving the outcomes and reducing the readmissions in these patients. Next slide. Here is the data from our publication of a couple of years back of over 2 million surgical cases. And I think it illustrates for you some of the points I would like to make. It shows you that readmissions actually exceed inpatient complications of care for the most part, that discharges without readmission is a common event among these patients. I would also emphasize to you that look at the third line down with coded complications. 81% of coronary bypass graft patients had one or more coded complications, but only 12% were outliers from their lengths of stay. And I think these kinds of data justify our looking at metrics other than what's coded on the record to identify what really happened to patients. Next slide. This slide illustrates the point in the bar graph that only about 55% of relative readmissions in major surgery occurs within 30 days. So we hear lots of criticism of, oh, it's unfair to make a 90-day bundle. But my goodness, we have consistently identified that 40 to 45% of relative readmissions following major surgery occur in the 31 to 90-day period of time. We're currently completing a major study of internal medicine admissions, and they're following the same pattern. So I think one can expect that the 90-day bundle is going to be the duration of responsibility going into the future. I would also point out in this slide that we had about 1.4 readmissions for every patient that had a readmission, showing that selected patients are readmitted frequently. And it gives us a guideline as to the kinds of complications that need to be the source of focus for prevention as one goes forward. Next slide. So comparative effectiveness. What is the opportunity for improved outcomes? And this is going to show you the value of risk adjustment, I hope. Next slide. So here is a study of about 130,000 Medicare colon cases from 1,900 hospitals in the U.S. The overall adverse outcome rate, with the patients having one or more of the 4 adverse outcomes that we've defined, was almost 28%. I was a little surprised by that. But when we did risk-adjusted adverse outcome rates, you can identify a dramatic spread in performance by different hospitals. These are risk adjusted, so that the top decile had about a 16% adverse outcome rate, and the poorest decile was over 39% of an adverse outcome rate. It's telling us that there is a nearly 24% opportunity if we brought all care to a standard. Next slide. Here's laparoscopic cholecystectomy, an operation that, as a surgeon myself and in talking with other surgeons, we view this as being a very safe, low morbidity procedure. Well, I'm sorry, but it's not. Not when you bring in post-discharge events. So we're looking at 10% adverse outcomes in the first decile, over 30% in the 10th decile. Next slide. To continue the analysis, this is a huge study that was just published in the Journal of Bone and Joint Surgery, looking at hips and knees. The spread in the outcome is fairly dramatic. In total hip replacement, we had nearly 10% of hospitals were 2 standard deviations poorer than the mean. With total knee replacement, we had 13.6% were 2 standard deviation outliers. The differences between decile 1 and decile 10 emphasize the opportunity that is present for improvement of care. Next slide. And in joint replacements, if you look at why the patients are readmitted, it can give you a roadmap for things to focus on in trying to improve care. So technical issues become a bigger issue with hips than with knees. Cardiopulmonary events tend to be greater in knees than in hips, in part because of the immobility that knees present. And then infection is always an issue for both. Interestingly, GI issues emerge in total joint cases, and we think that's due to immobility and perhaps the use of opioids in these patients. Abdominal distension, nausea, vomiting, severe constipation become major reasons for this population to be readmitted. On the right-hand side, as some of you would know, I've had a big interest in infectious problems in surgery for my entire career. And you can see those infections that emerge for these patients. The GI infection, as you might suspect, is C. difficile infection. I believe we can do better, and some hospitals are doing better now than others with preventing these readmissions and complications of care. Next slide. And this is cardiac surgery, coronary artery bypass, and valve procedures. And once again, we see the same spread. I'm trying to emphasize to you that the distribution of outcomes, regardless of what procedure you examine, tend to be equally distributed across a vast difference of outcomes, and that by knowing your outcomes, you can move forward in focusing care redesign to those areas where your hospital and your facility can do a better job. Next slide. So here is a graph of total knee replacement where we have plotted the risk-adjusted cost of routine cases, that's not complication cases, those cases that went from start to finish without an adverse event. And we've plotted that against the risk-adjusted adverse outcome of the hospitals. And we find, interestingly, that even hospitals that have excellent results commonly have very, very expensive care. More money does not necessarily translate into better outcomes. We see hospitals with the green dots that have high adverse outcome rates, but they're economical. Geez, maybe they needed to put a little more money into the care that they were providing. And then the upper outer quadrant shows the ineffective and inefficient hospitals with high adverse outcome rates and high costs of routine care. There's an opportunity for improvement, in my view. Next slide. You can carry this analysis down to the individual surgeon, and this is an analysis of a hospital looking at the routine cost of doing a knee replacement by surgeon, the costs of complication on a risk-adjusted basis by surgeon, and the total cost variance. And as you can see, Surgeon C appears to be having some serious problems. We have surgeons A, D, and F that are delivering care at costs less than what would be predicted. And Surgeon D has complication rates that are about the same as the population as a whole relative to his complication costs, or her complication costs, as I should say, but is very efficient in the care that's being provided. And this kind of data with feedback, I can assure you, will change behavior. Next slide. Next slide, please. So, care redesign is going to be essential for prospering under a bundled payment strategy. First and foremost, hospitals and surgeons must know what their outcomes of care are. And as I said earlier, and I will stand by it, I don't think we know the full scope of what happens to patients after their discharge. Yeah, if they come back to the office, the surgeon knows, but they commonly may not come back. They are commonly readmitted elsewhere. You have to know what your results are, and they need to be benchmarked. Transparency back to hospitals and to surgeons, I believe, will improve care. Patients with high-risk comorbidities need special both post-discharge follow-up and management. Prolonged length of stay for the inpatient portion of the episode of care actually predicts post-discharge adverse events. A patient that has had an inpatient complication, that will predict who comes back to the hospital. We find other things important. Anemia at discharge absolutely predicts readmission. You may not need to transfuse the patients, but you really need to have them monitored closely. Pain management is a major culprit. Either too much pain management or inadequate pain management. And I really think the concept of preemptive analgesia programs, where literally postoperative pain is managed literally before the procedure begins, is beyond our discussion today, but it's worth emphasis going forward. And then infection control always is a source of focus. And I would emphasize that post-discharge pneumonia, urinary tract infections, and C. difficile infections don't get as much attention as surgical site infection, but they become major reasons for readmission of these patients. Next slide. So, in summary, I think that it is important that you link objective and reproducible outcomes to the costs of the patients. The adverse outcome events will become the biggest driver of cost. In most hospitals today, I think we have squeezed about as much juice as we can get out of supply chain modifications of behavior. Oh yeah, I'm sure there's a few dollars there, but the big cost event that has to be avoided are major complications of care and readmissions to the hospital and returns to the emergency department after patients are discharged. The evaluation of outcomes needs to be across the entire 90-day spectrum. You need to have risk adjustment so you know who are the high-risk cases so that perhaps focused attention can be brought to those specific cases. That physicians and hospitals have to work together with a coordinated effort, and that rescuing of post-discharge events without readmissions becomes a key way under bundled payments to improve the margins to be experienced with care. And finally, I think understanding what complications and problems you have, providing appropriate incentives for people to realign their care with good feedback as to what their results are, I believe will reduce complications of care, provide better care for our patients at lower costs. So, with those comments, I will stop at this point, and I would love to address questions that any of you might have. Thank you very much.
Great. Thank you so much, Dr. Fry, for that fantastic presentation. With that, we're going to now begin today's question and answer session. If you would please all submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will now try to get through as many questions as we have time for. So Dr. Fry, one audience member is wondering if you have any advice on how to get physicians on the same page as the hospital administration.
Well, I think that one of the best ways is for the two groups to pool their effort together so that there can be a gain share or a financial incentive for physicians to be best performers, so that when the hospital and the physician both prosper or don't prosper together, that it will hopefully make people work together for common goals. I don't think that bundled payments are going to result in physicians prospering and the hospital suffering, or vice versa. It's going to have to be a team effort. And I say that with some caution because I know what has commonly been present in the past between hospitals and physicians when they are independent of each other. That attitude is going to have to change under a bundled payment strategy.
Great. Thank you so much, Dr. Fry, for clarifying that point. Someone else is saying CMS has rolled back its support for bundles. So how does that affect these ideas now?
Well, I have no idea what CMS is going to do in the next week or two. And I think the recent events would tell all of us that none of us really could predict what's going to happen. But I think for the long run, healthcare and CMS has got to find a way to bring quality and cost into focus. And I happen to think that ACOs, accountable care organizations, and bundled payments may be our last opportunity to do that. That we can't afford to have prospective payment fail. I'm not going to go into what might happen if that is the case, but I believe that our opportunity with bundled payments is before us. I do know that private insurers are very interested in bundles, and we have several private insurer clients that we are going forward and rolling bundles out. And my expectation is that we will see CMS come back to accepting the bundled payment strategy as a logical way to address quality of care and the cost of care.
Great. Thank you so much, Dr. Fry. And from your experience, what % of patients go to different hospitals for follow-up care instead of going to where they had the original surgery?
Well, that's an excellent question. And you know, I guess you could say, well, they were disgruntled with what they have received at the first institution or the first surgeon. I think that's probably not true. I think what happens is that patients live a distance away from their primary facility for where they received the operation. And patients kind of view all hospitals as sort of being the same. And so they will go to the nearest facility that is available to them when something emerges that represents an adverse event. And I believe that there's every opportunity through better communications and better interactions with our patients in the post-discharge period of time to avoid many of these readmissions. So I do think there are socioeconomic issues and there are geographic issues that drive a whole lot of readmissions. And traditionally, I think providers have not necessarily viewed that as being their responsibility. I think bundled payments will make it our responsibility, and that we can do a better job in avoiding a lot of unnecessary readmissions by having better informed patients and more efficient methods for them to contact us when something has gone awry.
Definitely, Dr. Fry. And this next question is a nice segue. So are you finding most of the issues are coming up during the inpatient period or the post-acute care period?
The last 20 years has seen the length of hospitalization reduced to a minimum. And so I think many of the complications of past years that were identified while the patient is in the hospital are not declared until after they are discharged. So the post-discharge space is incredibly important. It probably means there needs to be sooner follow-up of these patients after discharge when the length of hospitalization has been reduced. I do believe that the post-discharge period has the greatest opportunity for improvement in the avoidance of emergency department visits and readmissions. It does mean that clinicians are going to have to change traditional ways of post-discharge follow-up because we are pushing cases out of the hospital at a phenomenal rate. I mean, coronary artery bypasses are going home at 3 and 4 days. Geez, I can remember it when it was 2 weeks. It means that the complications are going to be declared after discharge. It means earlier follow-up and a more intense follow-up of our patients in the post-discharge period.
Great. Thank you very much, Dr. Tsai, for clarifying that. And someone's wondering, when you work with your clients to calculate bundled payments, do you interpolate from the big data sets that you cite on your slides, or do you work to get hospital-specific information so you're tailoring each offered bundle to a specific provider?
That is a superb question. We would like to have as much individualized data of the hospital, of our client's facility, as we can get. However, the problem with that is an extension of what we've discussed already, and that is that the hospital data may be deficient in identifying how many of their patients were in other emergency rooms and how many of them were in other hospitals for their readmission events. So this brings up the issue of hospitals and payers having a better relationship to develop coordinated databases that allows that knowledge to be available for improving care. So we still find that the CMS database has been useful, albeit it's only Medicare patients for the only Medicare patients and only over 65-year-old patients for the most part. But the reality is it gives us a clear picture of what's happening, and we find that some of our clients are a little bit bothered by seeing what has actually been their readmission and their ED visit rates among their patients that they've discharged. So we obviously want to have hospital-specific data across the full age range of their patients, but we still find CMS data can be quite enlightening in telling us what's going on and how specific hospitals benchmark against other comparator facilities.
Great. Thank you so much, Dr. Fry, for delving into the specifics there. Someone is wondering, if the bundled payment is paid to one entity, such as a hospital, how easy is it for the hospital to make a specific payment to a physician?
Well, you're getting into some of the federal legislation that interferes with people providing cost-effective care. Medicare actually will make provisions for shared savings programs. Our experience has been that if hospitals want to engage their physicians in a gain-sharing program, that you can actually petition the Office of the Inspector General for CMS and ask for a waiver. And the important part of doing that is that the methodology for sharing has to be clearly indicated to the actual savings that are created and by a formula of physician distribution of funds that is clearly linked to the saved money. If you have distribution of funds that is dissociated from savings, now you get back in, you get into anti-kickback legislation. Of course, many hospitals and physicians are solving that problem by physicians now being employees of the parent hospital, and then there has to be an internal negotiation about how potential savings may be shared as a significant incentive for clinicians to take all of this seriously and with rigor in trying to optimize outcomes and reduce costs.
Thank you for expanding there. And in terms of superutilizer patients, this attendee is wondering, what are your thoughts on rehab and recovering ACOs in regards to Medicare Part B providers?
Well, the whole issue of rehab and accordingly skilled nursing facilities are subjects of a lot of discussion. I suspect that there will be a movement away from inpatient rehab and perhaps more to ambulatory rehab. I think there are selected patients that still are going to need skilled nursing facilities, and if risk adjustment is done appropriately, you can clearly define who are going to be the patients that really do need them, and the costs of the skilled nursing facility should be factored into the bundled payment for that population of patients. It also means that hospitals and physicians will need to work with their rehabilitation facilities and with their skilled nursing facilities to optimize the efficiency of care that's provided for patients that really need them. So traditionally, patients can linger a while in selected skilled nursing facilities and in rehabilitation facilities when payments may be linked to a per diem. I think that will have to change, and there has to be a better interaction between these post-discharge facilities and the parent facility to avoid having those costs be excessive.
Great. Thank you so much, Dr. Fry. And it seems we have time for one more question here. So do you believe that many physicians aren't billing post-op for no charge? And they're referring to slide 22, meaning there's no data or low incidence of date?
That for surgeons, that is certainly true. Surgeons may not choose to bill in the first 60 or so days post-discharge, simply because that is rolled into the index hospitalization. If you look at the study of Jenks and et al. In the New England Journal, however, you will find that the readmission rates of the surgeons were actually much lower than the internal medicine cases, in which case we would believe that internal medicine will bill for everything that occurs in the post-discharge space. But I think the observation by someone there in the listening audience is absolutely correct. There may be a somewhat spurious exaggeration of patients not being seen after discharge by virtue that surgeons may not bill for return visits within that first 60 days.
Great. Thank you, Dr. Fry. And that seems just about the amount of time we have today. I want to thank Dr. Fry for his excellent presentation and to our audience for participating today. Enjoy the remainder of your day, and we will look forward to having you for future webinars.